want to welcome everybody here today. This is certainly a very impressive turnout, I think, particularly in terms of the physician representation. I also feel really honored to be here. I'm a psychiatrist by background, and although I'm certified in addictions, I certainly don't have anywhere near the expertise of the other folks presenting today in terms of opiate treatment per se. But that's really not what I'm focused on. What I'm really going to try to focus on is talk about care coordination, issues around access to care, and ideas of how we can improve that. We've had a lot of discussions, or some discussions in the planning sessions about the focus of my talk, and about the fact that the focus of the day is really on safety issues. And I guess my own take on it is there's probably no greater safety issue than access to treatment. You know, IRETA did a really nice job of demonstrating the growth in terms of access to methadone treatment over time. But you know, in the last year for which we had data, there were around 13,700 people that participated in methadone treatment programs. But we have a state with millions of people and undoubtedly hundreds of thousands of folks who have problems with opiate addiction. So there's still huge issues in terms of us reaching out to members who have problems and really trying to improve access to treatment. More on top or to the right? Got it. Thank you. I wanted to say just a couple comments about who community care is. I'm the chief medical officer there. And really, not so much that you all know about community care per se, but just to give folks who don't know much about how funding occurs for Medicaid enrollees in Pennsylvania a little information about that, because I think it does involve a lot of resources that you can use to help members. Community care is actually a managed care organization. It's part of University of Pittsburgh Medical Center, and was started a little over 10 years ago as the Health Choices program expanded to the southwestern part of the state. Health Choices is the name of Pennsylvania's managed Medicaid programs. There's both a physical health and a behavioral health component. The behavioral health component of Health Choices is separated from the physical health, mainly because the behavioral health programs, both mental health and chemical dependency programs, were historically funded and administered on a county-by-county basis. And there was a lot of concern that if you had several managed care organizations involved in those behavioral health and chemical dependency services in each county, that it would really disrupt the pre-existing system and service organization. So each county in Pennsylvania can decide how they want to organize the funding for behavioral health Medicaid services in their county. Most of the counties have chosen to partner with a managed care organization to help with that. And so we're one of the managed care organizations that the counties work with. And certainly part of the charge to our company, really from the folks who developed the company as well as our current board of directors, and Mike Flaherty actually has a lot of responsibility for the initial development of community care, and has spent most of the intervening years as a member of our board of directors as well. The question we always get from our board of directors is, what are you doing to make services better? What are you doing to help the communities that you're working in? We're certainly not supposed to lose money. We are a not-for-profit. But really the emphasis is on what we can do to make services better, and certainly one of the areas that we're asked to look at is chemical dependency. In the next slide, the main thing that I wanted to highlight is that we do have consumer, family, and provider representation on the board of directors. When I first joined community care in my current role, which was now around 8 years ago, I thought it was really a great idea to have consumer and family representation, because it was important to have a link back to the members and their families so they would know what we were doing and to hear their questions. But it's become clear to me over time that they're actually the most valuable members of the board of directors and really of everything that we do. There's lots of information and ideas that we hear, not only in the board of directors but in other forums from the consumers and families, that we would never think of ourselves. You know, like the professionals always continue to talk to ourselves, but we have kind of a limited pool of ideas. And that's really the best way to expand it. And as I was sitting here today, actually looking around the conference, it struck me that, and I'm as guilty as anybody else because I was on the planning committee, but really we shouldn't have a conference like this without family members and consumers present. And so I really challenge all of us to follow up on that theme going forward. The one other theme that I want to emphasize as we talk through this this morning, and you'll hear more about this later in the day, there's a separate presentation, is the idea that Mike raised in his opening statement about the idea of recovery in drug and alcohol services. Certainly, treatment is important, but clearly what's most important to the folks who come for treatment is not really the details of their treatment, but what happens in the rest of their lives. And that's really needs to be, I think, our goal going forward, is doing what we can to really support the development of the rest of their lives. And I really feel this is an audience tailor-made for that message, because clearly there's always been, historically, there's lots of controversy around methadone treatment for folks with opiate addictions, and how did that fit into the traditional drug and alcohol model of recovery, which was typically thought of as abstinence. But I think you all are really the leading model in the field of drug and alcohol for the goal is really to help members with their lives. And whatever modalities best support that is really what we should do. This just gives you a sense of the growth both of our company as well as the expansion of the Pennsylvania Health Choices program. About 550,000 of these members are in Medicaid programs. The rest are in UPMC commercial and Medicare plans. These are the counties that we work in. And in our VITA slide about where methadone treatment programs are, you see there are many more counties that have programs now than did 5, 6, 7 years ago. But still, if you look at all those counties across the top of this state, most of them don't have any methadone treatment programs. And I'm going to show you a little detail about the results of folks not having access to those programs. One other theme that I wanted to encourage folks to focus on was really to use the resources of both the county county authorities, the county-based drug and alcohol treatment programs, as well as the Medicaid-funded managed care organizations in your county. There's certainly lots of resources that can help in terms of care coordination, linking members to other services, making sure members stay in treatment. Certainly one of the roles of our care management activities is to make sure that members' needs meet the medical necessity criteria, which in Pennsylvania is the PCPC, the Pennsylvania Client Placement Criteria, for drug and alcohol, for the services they get. But really the main task is really trying to facilitate care, look at, make sure the care is meeting kind of agreed upon quality standards and coordination of care. And one of the things that our care management efforts try to emphasize is how to include the idea of recovery in members' treatment. We actually we have a statewide effort that we've been working on in terms of recovery for people with mental health disorders. And we've had several web-based seminars for that, and actually had one just earlier this week that we had, we think, around 1,200 people participate in, either by web or by phone. And the focus of the seminar really was on treatment planning and how to incorporate recovery principles into members' treatment plan. And I think that that's certainly as appropriate for folks in drug and alcohol programs as well. The treatment plan is really not just what medications is somebody getting or how often they're in treatment, but how does that treatment help other parts of their lives? How does that affect their employment, other psychosocial issues, and what steps do they want to focus on in their treatment program to help them accomplish those other goals? I'm going to skip the quality program. And I often get asked this question in several different variations, which is, why would a managed care organization want to expand services or improve access to services? Won't that just increase your cost? It seems counterintuitive, and I guess kind of counter-historical to folks' experience with other managed care activities in the past. But in addition to being part of our mandate and part of the mandate we get from the Department of Public Welfare in terms of our work. There's no question that the key driver of the money we spend on mental health services is addictions. Certainly there are lots of folks with schizophrenia, bipolar disorder, depression, and other disorders who don't have concurrent addictions, who spend money in treatment. But we've done lots of analyses of people who use